I'm Ian MacDonald, and I'm pleased to provide you with this information for the Choroideremia Research Foundation. Choroideremia is a slowly progressive inherited retinal dystrophy. It's rare, affecting perhaps 1 in 50,000 in any general population. It's caused by loss of function mutations in the choroideremia gene. It is inherited in an X-linked recessive pattern, thus it mainly affects males but can affect sometimes female carriers. It accounts for approximately 4% of all blindness. A classic course of choroideremia in an affected male can be seen in the images. On the left is a teenager with choroideremia. This individual may have night blindness in early childhood, and the fundus has a mottled appearance. With time, into the 20s, there may be a progressive narrowing of visual field, and there may be areas in which the pigmented layer is missing at the back of the eye, seen in the black arrow. You can see there's progression with age, and in the next frame, you'll see an individual in his 40s, where you can see the deep choroidal vessels quite clearly around a small area of remaining retina in the macula. The optic nerve looks quite healthy. On the far right, this would be an individual in late adulthood, the 60s or 70s, with perhaps a very small patch of remaining functional retina in the central area of the macula. There will be retinal pigment epithelial changes, as you can see on this image of the early stage in comparison to the normal fundus. You see the salt and pepper-like appearance outlined with the black arrows. There are areas where the pigment layer is more transparent, allowing one to see the deep blood vessels of the choroid, illustrated with the white arrow. From the early stage of choroideremia to the mid stage, there is a change in the pigment layer, and it may be possibly absent in the peripheral part of the fundus, as outlined with the black arrow. The pigment layer is only preserved in the central area, in this particular frame on your right, and that area outlined by the white circle is the macula. Stage, there's an exposure of the white sclera with a whiteout-like appearance and extensive choriocapillaris atrophy. There can be decline of visual function with difficulty seeing at night, generally occurring after the age of 50. And in rare cases, carriers may exhibit severe symptoms similar to those of an affected male. A female carrier on the right in comparison to the normal fundus. You can see the normal retinal image on the left below, as taken with what we call an optical coherent tomographic scan. Compare that with the choroideremia carrier on the right, and you can see that there is significant thinning of the central retina, as seen with the fundus photograph with the white arrow and also the white arrow on the OCT. See the fundus of a female carrier on the left, that's a photograph, and the autofluorescent image of the same eye on the right. There would appear to be speckling of the pigment layer, representing a deterioration of the retinal pigment epithelium, outlined with the white arrow, sometimes with retinitis pigmentosa. So let's talk about these two disorders. Choroideremia is inherited in an X-linked recessive manner. Retinitis pigmentosa can be inherited as a dominant trait or a recessive trait that is non-sex linked, and also an X-linked trait. Choroideremia is caused by mutations or variations in the choroideremia gene, whereas retinitis pigmentosa is caused by mutations in more than 60 different genes other than the CHM gene. Choroideremia affects mainly males, but retinitis pigmentosa affects both males and females. As you can see, the symptoms of both are similar, and the electroretinography findings show the same problems with seeing the light in the dark, and in the late stages can be non-recordable. The OCT findings are similar in both of these disorders, showing retinal thinning, loss of the retinal pigment epithelium photoreceptors, preservation of the inner retinal layers, and in some cases, retinal tubulations. Here are the retinal findings in RP that differ from choroideremia in the later stages. One can see the optic nerve at the white arrow is much paler and giving a waxy appearance in RP, different from choroideremia. Also, the blood vessels, which are seen with the black arrows, are much thinner in retinitis pigmentosa than in choroideremia. Finally, there are areas of pigment termed bone spicules that are more commonly seen in RP, outlined in the yellow arrows again, than in choroideremia. And finally, cystoid macular edema is more common in RP than in choroideremia. If you have been clinically diagnosed with choroideremia, there's free genetic testing available through the CHM.org resources. You can find that on the web, and you can look at other genetic testing resources at the second web address. Here are some additional resources from the Choroideremia Research Foundation, the Foundation Fighting Blindness, both in the US and Canada. There's a choroideremia patient survey, which you might want to look up, and you might continue to be interested in joining the choroideremia patient registry. If you have questions or comment about this presentation, please contact Corey MacDonald at the Choroideremia Research Foundation or myself through Stacy Stone at the email address. And for more information regarding your care options, please contact your local ophthalmologist. Thank you for listening. I hope that you've enjoyed this presentation.